now I want to welcome Dr. Nick Kashey. Dr. Kashey is the Clinical Vice President for Population Health at Legacy Health and is a Portland resident. He has been deeply involved in Legacy's COVID-19 vaccination outreach efforts to educate and vaccinate marginalized communities, as well as supporting their employee COVID vaccination mandate, ensuring all employees have access to information to make their decisions around getting protected against the virus, which includes an internal hotline for any employee to call and have a one-on-one conversation. Here is why he said he's excited to be here. He said, "My wife is an educator, and I've seen how important it is for kids to be together in school safely. Vaccination is how we get there." Welcome, Dr. Kashey.
Thank you so much. I think I'd like to start off by emphasizing, so I'm going to share some facts and just some of the science around the common concerns that people raise and a lot of the kind of pushback that people in this wonderful advocacy group will probably run into. But I really want to kind of emphasize that these are kind of, this data and facts are not the club to kind of beat people over the head with, and really emphasizes Dr. Hassan's kind of message of the things I'm going to present today are really kind of the surgical instrument to pick very selectively, only in the right instance and time, because the real hard work is really understanding what somebody's internal motivation is or where their pushback or concerns or questions are coming from. And spending all the time, 80% or 90% of the time has to be spent asking and listening and exploring why people feel the way they do, rather than just talking at them, because like everyone else is saying, that's like running your head into a brick wall. I'll have to say personally, I've had to work on that over the course of this pandemic. I see patients up in St. Helens, saw somebody in the chat from St. Helens, shout out to St. Helens. Honestly, like I have very quickly had to adjust my approach. Just like Dr. Hassan was saying, I had a kind of quick screening question of, in the beginning, I tried to kind of just talk to everyone and was like literally like running headfirst into a brick wall emotionally all day, and it was not sustainable. So in terms of that personal wellness, I think that's a really important kind of skill to hone. And also to remember, nobody wakes up in the morning and says, I'm going to be super obstructionist and I'm going to try to make the world a worse place for everyone, right? Like that's not where people come from. And I think it's really important in these conversations to acknowledge that every single person is trying to make the right decision for themselves and try to do the right personal thing for their sense of their community. And people come from a lot of different communities in this state. There's a lot of interesting social pressures and dynamics within those communities. So I'll share a story. One of my patients, who I did convince to get a vaccine, the main thing that got her to get that vaccine was I had to convince her or help her understand that we weren't going to send any automated letters or phone calls, because she was mostly afraid of her sister, whom she lived with as an elderly lady, lived with her sister, and she was terrified that if her sister found out, her sister was vehemently anti-vax, if she found out that was way worse than anything that could possibly happen with the vaccine. So once we kind of cleared out our whole process, and so, yep, you can come back and get your second dose. Now your sister does not need to find out. That was all it took, right? So digging into those whys is really how you're going to help turn people and understand and help make those individual ones. I think it's also just want to put out there, and this is a whole topic in and of itself, but in working in marginalized communities, to really how important it is to acknowledge that structural racism exists in medicine and healthcare, all the history in many of the communities of color. Putting that on the table is really important, especially, for a kind of cis white guy like me. I think making those acknowledgements of those concerns and fears is an important step in the process. And I will also just emphasize the I statement. I do really strongly believe in the I statement of like, this is what helped me. This is what helped me make my decision for myself and let other people make theirs. All right, so to jump into the slides, and for some reason, there we go. Let me jump in. So, I'm hoping the slides are showing. So these are a couple of topics we're going to go through in terms of common pushbacks that you'll run into in this process. natural immunity. So a lot of people are kind of leaning on natural immunity or hoping that natural immunity will be enough to get them through this process. COVID does provide some natural immunity, but we don't know nearly as much about the course, the length, and the degree of protection that we see from natural immunity as opposed to vaccination. The study that, and this evidence-based piece that I lean on a lot in some of these conversations is that there was an important study that compared reinfection after having the real deal COVID against a breakthrough infection after vaccination, and there showed twice as many reinfections through natural immunity as in the breakthrough cases through vaccines. And so I will share these slides. There's links in a lot of these slides to those original articles and some of those kind of data sources. So we'll make sure we get those to you for your reference if you need to use them for future. There's also data, and I couldn't find the link, but I know I've seen some data that there is people have had. There's a lot of people will also say, well, I did have it, I don't need to get the vaccine. And we do see that there's extremely strong, so that really kind of in a way, the best immunity is people who did actually originally have it and then got their vaccine afterwards. It is still also some people early in the disease or early in the pandemic, we were asking people who had real COVID to wait. And that was more of a supply demand issue when vaccines were still really scarce. We kind of prioritized people who hadn't had anything. But ever since the vaccines became more widely available, as soon as you're done with your isolation period after having real COVID, if somebody does unfortunately have it and thankfully recovers, they can still go get their vaccine as soon as they're done with their isolation period. The long-term side effects, and Dr. Zhang touched on some of this already, but vaccines don't stay in your body for more than a few weeks, right? Your immune system actually tears them apart. That's kind of the whole point, is that the vaccine teaches your immune system how to recognize something. And in that process, it's essentially chewed up. Every other vaccine, we've developed, lots and lots of other vaccines. If there's going to be an issue, it'll show up in those first 6 to 8 weeks. And again, there's some documents from the CDC that kind of go into some detail on some of those previous ones. Anecdotally, the last one I remember was the rotavirus vaccine, the first rotavirus vaccine that came out in the 90s, which again, very similarly, very quickly was identified as having some problems. These vaccines have been on the market long enough and in people's bodies for long enough, over 1.5 years at this point. So I think we've really got a good sense of the safety of the vaccines. And as Dr. Hassan also said, nothing has been under the microscope the way this is. And the vaccine adverse reporting system, the VAERS system, I think the controversy or the discussion about the Johnson & Johnson vaccine and the clots that were related to those in younger women of childbearing age are actually a testament to how well we monitor for side effects, right? So there were 6 clots in the entire United States, spread out different cities, states, after 6.8 million doses had been given. So it's literally less than 1 in a million chance to get one of those blood clots. And we found 6 things in 6 individual cases in the United States within weeks, right? So again, it's just a testament to how effective that's. So back to the speed of rollout. So again, as Dr. Sun mentioned, there were no safety steps that were skipped, and it was the billions of dollars that really allowed 100% focus on the vaccine. So they dropped everything else they were doing. And they also skipped any delays of having to essentially go and ask for money between the phases and start on production before the trials were complete, knowing full well that there was a risk that if they didn't get a thumbs up, they were gonna have to go toss everything in the trash and start all over again. But because of all the money they had, that allowed this acceleration. So just to look at it from a visual standpoint, in the normal process, you've got this in early development phase and these long arrow delays between okay, now we got to convince everyone, let's keep going. And we do safety phase 1 and then safety phase 2 and 3. And then as long as everybody agrees, then we're going to start making it, which takes, a batch of COVID vaccine takes 8 weeks to produce. And then it eventually ends up as shots in arms. And with the 100% focus and all the dollars, all those phases were still the same length, but they were just, they were able to do them back to back to back without having all those long kind of administrative delays. But the actual testing itself was all the same. The fetal cell issue is a comes up very frequently. So there's three phases to vaccine kind of creation, right? There's the development, which is inventing it, testing it, which is making sure it's safe to use, and then the production, making large enough quantities of it to distribute to people. Moderna and Pfizer did not use any fetal cell lines for development or production. The testing phase did involve testing against some two fetal cell lines, which were established in the 1960s. And we'll talk a little bit more about that in a second. Johnson & Johnson does use those same fetal cell lines for development and production, but there's still no cells in the vaccine itself. There are no fetal cells that are being injected into a person. And so these cell lines that we're talking about were from a couple of elective abortions in the 1960s, and those cells have been kept alive in the labs. And those cell lines are used to test all kinds of other medications. I mean, most over-the-counter medications, Tylenol, aspirin, Tums, Benadryl, I mean, there's a laundry list of other day-to-day things that have actually went through exactly the same process. So the Catholic Church has endorsed the vaccines. Most pro-life organizations have endorsed the vaccines. So that's kind of the stand, that's where fetal cells fall in. The DNA question, so a lot of people ask about changing the DNA. And so I'm gonna geek out for a second, get a little technical, because it is complicated, but your body uses messenger RNA every day to express your genetic code. So if you take a normal, healthy cell, our cells all have DNA in them. They also have a thing called a ribosome, which is basically like a protein factory. So on a normal, everyday, your DNA sends a little messenger RNA, which is essentially like it's almost like an order ticket in a restaurant, to the ribosome, and the ribosome will make proteins that your body uses to do things, making antibodies, everything that you're building muscle, whatever it is that your body, that your DNA codes for. This is the basic process how it works. So these vaccines don't do anything to the DNA. What these vaccines are is essentially a new order ticket that gets sent in, that goes to that ribosome, that protein factory in the cell, that produces the spike protein, just the surface protein for your immune system, to trigger your immune system to recognize. But if you'll notice the DNA part, there's no direct interaction there. The vaccine doesn't actually get in there in any way, shape, or form. The vaccine is using part of the normal process that your body's cells use to function. I'll touch upon pregnancy. So there were 2,500 pregnant women included in the initial trials, and they watched those women very closely. There was no increase in miscarriage rate. There's no increase in birth defects in the population, and then all those babies, the babies that were born while those women got vaccines were all fine. Again, there's a link for some data in there. Breast milk also passes antibodies that can help protect babies and not vaccine. It doesn't, so we know the vaccine doesn't transmit, but the protective antibodies do, which is why it's actually really helpful for the babies to get vaccinated. I think on a personal note, we have seen horrifying cases of COVID during pregnancy. We have had to deliver babies by C-section while their mothers were still intubated in the ICU. There have been fetal demises. I mean, I can't even begin to express the dangers of COVID during pregnancy. And the stories are absolutely heartbreaking. So some people say, well, we've been back in school and everything's going okay. Why do we need, we've got masks, some people say, well, why aren't the masks enough? Why isn't spacing out enough? And that's where I like to use this slide about the kind of Swiss cheese model, is that there's nothing as perfect. And the more layers we add to protect, vaccination isn't 100%, masks aren't 100%, and we can be honest about that. Hand washing isn't 100%, but if we layer all these things in place, that's how we get to a strong kind of protective effect on those in terms of the spread of the disease. And we'll run through my last couple ones. So the other question is, there have been some stories recently, especially out of a study in Massachusetts, where there was an outbreak amongst a lot of vaccinated people, where a lot of people have kind of latched onto the fact that people who are vaccinated who get an infection still have a very high viral load. And so there's the kind of thought there is like, well, if it's not really doing anything. So it comes back to the basic math of that there's still far fewer infections in vaccinated people than there are in unvaccinated people. The other part is that unvaccinated people are still at far higher risk of hospitalization and death. And that study measured viral load, but it didn't necessarily measure infectiousness. And there's newer data that's actually starting to suggest that that same viral load in a vaccinated person still isn't going to pass on. It's different than it is in an unvaccinated patient because that virus is actually covered in antibodies, which the other one isn't. And so it doesn't necessarily behave the same. So leaning too heavily on that Providence study is not really scientifically sound, and there's still more research to be done to figure that out. And that's it. Sorry, I think I might have gone a little over time, but.
That's okay. That was a really terrific presentation. I think that was probably one of the best descriptions of how messenger RNA works that I've ever seen. So thank you so much. I really appreciate it.